Of course, being a pharmacist, I'm going to talk about the medications that we use to treat Parkinson's. Lots of medication options. We're going to try to briefly kind of hit on all of them and really focus on, why do these work the way that they work and what is their place in therapy? Because I feel like sometimes, specifically with Parkinson's disease, we can feel like, come on in. We can feel like there are so many options and it can get kind of overwhelming. And you can say, well, why would I use one over the other? And of course you have Dr. Pabolnarak, Dr. Bailey, Michelle Stowe, any of your neurologists, myself, to help kind of guide you and make that decision with you. But just kind of want to put these all on your plate as well, just so that you're kind of aware. When we bring up a medication, you can say, okay, I've kind of heard about that one before. So we will start by doing a very, very broad overview of like the general reason why these drugs work in Parkinson's disease. And then we'll kind of go into talking about each of them individually. We will first start by talking about medications used to treat the motor symptoms in Parkinson's disease, which are those cardinal symptoms: the slow movement, the rigidity, the tremor, the shuffling gait. And then kind of at the end, we'll talk about all of these medication side effects because they're all very similar. So I'll kind of talk about general approaches to how we manage those and what to look out for. And then we will talk about non-motor symptoms of Parkinson's disease and our general approaches to treating those. Okay. All right. So first, of course, I'm sure you guys have all been educated in the past that Parkinson's disease, we consider it a neurodegenerative disorder. So basically, neurodegenerative disorder just means that there's some kind of neuron death or damage, or basically nerve cell death. The specific nerve cells that are targeted in Parkinson's disease are those that live in this fancy part of the brain, right at the tippy top of our brain stem here, this pink structure called the substantia nigra. All you need to know is that those cells are kind of what produces the neurotransmitter dopamine for our body. So dopamine's the problem here, right? So those aren't producing dopamine. Therefore, the other parts of our brain where dopamine is very important to controlling our coordination and our movement, such as the basal ganglia, that little hot pink purple structure there, that kind of controls movement in your body. When it doesn't have enough dopamine, we get slow movement, we get rigidity, we get like the gait shuffling, we get that tremor. So that's the whole problem. There's not enough dopamine in that part of our brain. So how are we going to treat that? We're going to give dopamine. So let's go to the next slide and kind of start talking about our gold standard of therapy for Parkinson's disease, which is carbidopa, levodopa. I would bet that most patients who have been diagnosed with Parkinson's disease have heard of or been on this medication either in the past or currently. So levodopa is just the gold standard. The way that this medication works is levodopa turns directly into dopamine in our brain. Like once you take it by mouth, it gets absorbed in your stomach, and then it goes into your brain and turns into dopamine. So levodopa is actually the active drug here. That's the important part, okay? Carbidopa, that formulation of it, you might have always wondered, like, why are there two words in this one drug? That's because they're two different drugs formulated together in a tablet or a capsule. So the carbidopa, actually, it's really interesting. It just works kind of like a Trojan horse. So it doesn't actually have any activity. But the problem is if you take levodopa alone, it can be turned into dopamine in your stomach, and we don't want that. We want it to be turned into dopamine in your brain. Because in your stomach, we don't need dopamine in our stomach. It causes a lot of stomach upset. So we formulated it with carbidopa to prevent that from happening. The carbidopa basically kind of distracts all of those things that would turn it into dopamine prematurely in our stomach and allows that active drug, the levodopa, to get into our brain where we want it. So that's a pretty broad overview of how this medication works. But the long story short, levodopa turns into dopamine, and we have a dopamine deficiency. So that's why we use this medication. All right, so in general, the whole point of this slide and of this conversation is to just describe that, if you're having to take carbidopa, levodopa 5 times a day instead of 3 times a day, that is normal. And our whole job is to cater your medication regimen to you so that you don't experience these freezing times. So sometimes we have to kind of get creative in the dosage forms that we're using. Maybe first thing in the morning, you see this red box here. So that's just designating, you wake up, you haven't taken carbidopa, levodopa since 8 p.m. the night before. It doesn't last that long. You wake up really stiff and rigid, and it takes a little while for that dose to start working in the morning. So maybe we start looking at maybe dosage forms that work a little faster to help you out in the morning. Basically, we're just going to have to customize it, and it's going to change throughout the course of your disease. All right, so let's go on to the next slide and talk about maybe some carbidopa, levodopa dosage form options that might be good for patients who kind of get to that point where they're having to take it 4-5 times a day, because that can be really difficult. So we have, let's see, Rytari. I think if you just want to click to the next slide. Oh, okay, well then this is a good spot. Let me just kind of fit in our dietary considerations with carbidopa, levodopa while we figure that out. So you might have heard carbidopa, levodopa taken at least 3 times a day, right? But we need to separate it from food. Has any of you guys heard that before? Yes. So the issue with carbidopa, levodopa and food, it's a big catch-22. Okay, so some of the side effects of this medication is that it can cause nausea, make your stomach hurt. So we don't want that to happen. And that is worse if you take it without food. But you're still not supposed to take it with food. And why is that? So it's actually not all food. It's just protein. So protein basically, long story short, can kind of bind on to that levodopa in your stomach when they're in your stomach together and prevent that from going to your brain and having its activity. Okay, this isn't a problem for every patient. Typically becomes a problem as we get like later in the disease and we're having to change your doses around a lot. But that's really difficult. In general, we recommend carbidopa, levodopa be taken at least an hour before you eat protein. But when you think about that, let's say we take our carbidopa, levodopa at 7 a.m. when we wake up. Have to wait until 8 to eat our breakfast. Then we take it again at 11. We have to wait until 12 to eat our lunch. We take it again at 4. We have to wait until at least 5 to eat our dinner. That's talking about your whole day is becoming regimented. So that is definitely how we recommend taking it. But if you are someone who cannot do that, cannot fit that into your schedule, and you want to try taking it with food, like we're going to listen to you and your symptoms. We're going to allow you to try that and see if your symptoms are a little worse by doing it. If so, we can talk about other ways to kind of move that protein around in your diet. Yes.
You're saying that if we do an hour afterwards to eat, what if you miss your timing off by about a half hour or so?
Exactly. So if you miss your timing off by about a half hour. Yes, of course. Thank you. He asked, we recommend that you take your medication, then an hour later you eat. Like, what if you forget your medication and you're more like only a half hour separated? Like, that's okay. The only risk we run is like maybe that levodopa dose won't work as well. And that's a maybe, okay? It's not a definite. Go back on the regular schedule. Don't disrupt your entire day because you're 30 minutes late on a dose. Absolutely. So again, it's something we monitor for. If you are not able to separate your carbidopa, levodopa from your meals, we're going to let you try that. We want you to try that. We want to make it as easy as possible on you. We're just going to monitor it closely and see if your symptoms worsen, which would tell us those levodopa doses aren't working as well when you're taking it with food. But maybe yours aren't affected. We just have to try to see. So that's kind of the skinny on food. But as I said, if you are taking it with your meals because you can't separate it just because of quality of life, timing of your daily schedule, then we might talk about other methods. Maybe, eat 3 times a day like you normally do, but maybe try to preserve your protein for like the evening time so that your breakfast and lunch aren't impacted by the food that you're eating with your carbidopa, levodopa dose. That's just one method we might talk to you about, so that would maybe mean let's focus on like carbs and fats during lunch and breakfast. And then at dinner, that's when you can kind of have your protein for the day. Protein's important. We do not want you to stop eating protein, but that just might be one way we can customize it if we're having this issue. So we can work with you. In addition to the tablet forms of carbidopa, levodopa, we have Rytari here. So Rytari is an extended release capsule of carbidopa levodopa. It's a little fancy. So it's this capsule medication with like beads inside of it. And those beads are what the active medication is. That's the carbidopa levodopa. So 1/3 of these beads in each capsule are immediate release, which means they'll peak in 30 to 60 minutes. They'll kind of help you unfreeze in the morning. But 2/3 of the beads in that capsule are extended release. So they should be lasting more like around the 6-hour range is kind of the goal. So it can be a little more convenient. It can be really useful for patients who get to the point where, oh man, I'm having to take my carbidopa levodopa immediate release like 5 times a day now because it's only lasting like 3 hours every time I take it. So this might be an option for those patients. It's brand name. Of course, it can be expensive. We do everything we can. That's a big role that I play in our clinic, doing everything we can to make sure you have access to these medications. So we can absolutely work with you there. But that's kind of the skinny on Rytary. So let's go to the next and final carbidopa levodopa dosage form that we currently have. Has anyone heard of a Duopa pump? Okay, so Duopa. This is a fancy surgically implanted pump. So you have a little like pump machine here. You see that cassette that holds the medication, and that cassette and that machine infuses the medication 16 hours a day, sometimes 24 hours a day, straight into your stomach. So in patients who are taking carbidopa levodopa 5 times a day, 6 times a day, they're still having freezing episodes that we're having to give them something to treat with that quickly. This might be a good option. Inconvenience factor, out the roof, right? You have to have surgery to have this implanted. It's reversible, but that's a hassle as well. There is a lot of patient and caregiver education that's required, of course, for patients who use Duopa. Because your caregiver and yourself have to be knowledgeable about how to use the pump and make sure we're using that safely. But it's really customizable also. So you're getting this constant dose of carbidopa levodopa, but we can set it to where you can give yourself like a morning bolus dose if you have problems like unfreezing in the morning once your pump starts. We can set it to where every 2 hours you're allowed to push a button and administer yourself an extra little dose in case you're experiencing any symptoms at that time. So it is really customizable. It is a potentially great option, but there is a huge like inconvenience factor to this option as well. Very exciting things in the pipeline. We expect carbidopa levodopa subcutaneous pump to be approved this month. So that might be a little more convenient of an option. The patient education is still going to be out the roof. We're still going to have to make sure everyone on the team is comfortable with you using it, but subcutaneous pumps just mean that there's basically a catheter right under your skin, like into the fat layer. So the levodopa can be absorbed straight from the fat layer under your skin instead of having to surgically implant this into your stomach. So that might be a very exciting option that we have for patients who have really frequent dosing intervals or take many, many tablets throughout the day. Okay. Go to the next slide. And so those are the staple agents, kind of like baseline agents for probably 90% of patients who have Parkinson's disease. We're going to put those on first. We're going to try to optimize those. Sometimes we need to add on some agents. So I'm going to talk about each of these individually and kind of focus on what their role in therapy is. Like what about your case would cause us to say, let's use this over the other. Okay, so let's go on to the next slide. And first we have COMT inhibitors, catechol methyltransferase inhibitors. You don't need to know that. The point of these agents is that it basically inhibits the little enzyme or a little machine in your body that breaks down levodopa. Okay, so the point is that adding these medications onto your carbidopa levodopa is going to allow your carbidopa levodopa to last longer because it's not going to be broken down by your body. Okay, so good options for patients who used to take carbidopa levodopa 3 times a day. Now they're taking it 5 times a day. Maybe instead we can add on one of these and allow you to take it only 3, maybe 4 times a day. So trying to eliminate one of those dosing intervals here. Entacapone is the one we generally use. And it's a 200 milligram tablet that you take with every single carbidopa levodopa dose. So if you're on carbidopa levodopa 3 times a day, you're taking entacapone right there with it. Take it at the same time. There's the more convenient opicapone or Ongentys in the gray box here. That is only 1 capsule taken at night, so much more convenient. You don't have another big pill to take with your carbidopa levodopa. It's newer, it's brand name, can be expensive. We typically have to try the entacapone first to get that approved. And then we have a third option, tolcapone, that we do not use because it can cause liver damage. So we're not going to do that to you. So we're not going to be using that one. But place in therapy, add it on to your carbidopa levodopa. We might be able to kind of extend how long that dose is working if we take it with it. Okay? Let's move on to the next class of add-on agents, which is, I believe, the monoamine oxidase inhibitors. Next slide, please. Yes, monoamine oxidase inhibitors. So monoamine oxidase, or MAOB, I misspelled it on the title slide here. I recognized that yesterday. But monoamine oxidase is an enzyme in your body that breaks down dopamine. So the other one breaks down levodopa. This one breaks down dopamine. Important because levodopa turns into dopamine. Also, we still have some natural dopamine being produced in our brain. So we don't want that broken down prematurely. We want it to work and let our muscles move the way we want it to. So these medications inhibit that. These also may be an option for patients who are first diagnosed with Parkinson's and maybe their main symptom is just a tremor, like while we're early in the disease and like just now starting to experience those symptoms. These might be a good option to just put on as like a single, like before we even start carbidopa levodopa, maybe we can use these. They kind of have a role there as well. But significant drug interactions with these agents though, because there's agents in this class that are used as antidepressants. Selegiline here that we use at a lower dose for Parkinson's disease, at higher doses is actually used for as an antidepressant. So we have drug interactions there. We have to be really careful if you're on medications for anxiety or on medications for depression or nightmares or a multitude of medications. We have to be really careful with these. So that can decrease their usefulness in actual practice, but we have selegiline, rasagiline, and safenamide. Those are all oral tablets or capsules that are dosed anywhere from 1 to 2 times a day. So again, maybe a useful add-on agent to let your levodopa last longer, maybe a useful agent early in the disease with patients who only have like a tremor as a symptom, okay? And then we have dopamine agonists, which are very popular add-ons for therapy. And you might have seen these medications, pramipexole or Mirapex, ropinirole or Requip, and then we have rotigotine or Nupro. So these are very commonly used for restless legs. So if you know anyone, if you've ever experienced restless leg syndrome in your life, it's very likely that your friends or family that experienced that have been on these medications. These are kind of first line for that. So they work for multiple different things. But in the context of Parkinson's disease, the way these medications work is they're not dopamine, but they mimic the actions of dopamine. So they attach to those dopamine receptors in the same way that dopamine does. So it kind of mimics that activity. Because they're kind of like a knockoff dopamine, they may not be as effective as our carbidopa levodopa, but they definitely help. So they might be a good supplemental agent for patients who are on carbidopa levodopa and continue to experience symptoms. They are another potential agent for patients who are early in disease and might just have a tremor. So this is also something we might start this first until your symptoms kind of increase. Do you have a question?
What was the duration of your add-on?
So for this one or the last one? So the last ones are anywhere from 1 to 2 times a day, depending on like which agent you pick. These are typically taken 3 times a day. So we would take them with our carbidopa levodopa doses. And the question was, how long, what's the duration of action, or how long do these agents work? So we would take them 3 times a day. They would last about 6 hours, 6 to 8 hours each. So again, roll-in therapy, these would be decent options if we're still having symptoms on carbidopa levodopa, or if you've just been diagnosed with Parkinson's and you're having a tremor, but not many other symptoms yet, they might be a good option. Okay. All right, so that's dopamine agonists. Let's go on to the next slide here. And we have amantadine. So amantadine is also a dopamine, it's considered a dopamine agonist, but we know it works in some other way. There's some other unknown mechanism about it. So I put it on its own slide because it kind of has a different utility, a different place in therapy than the dopamine agonist that we just talked about. This one is specifically used to reduce dyskinesias. Does anyone know what dyskinesias are? So dyskinesias are involuntary movements that can happen if we give you too much dopamine, okay? So we're giving you dopamine to unfreeze, to make you less rigid, to make your tremor go away. But if we overshoot that and we take too much dopamine, we risk something called dyskinesias. So dyskinesias, you can think of them as being like tics or spasticity. So kind of having spasms can be very bothersome, very, very bothersome. So, you know, it's really, and we hate the situation when, okay, your carbidopa levodopa regimen we have you on is working very well to unfreeze you, to treat your symptoms, but sometimes you're having these tics. So our options are decrease your dopamine dose, decrease all of your other medications that are doing well overall, but causing this side effect, which we absolutely will try, but we risk worsening your Parkinson's symptoms. The other option, if we try that, it fails, you're like, nope, I would rather be able to move and just treat these tics separately, then we can try a Mantidine, adding it on top of that. So it's a really great option. It's only taken once a day in one formulation. Gocovri is a brand name, a Mantidine capsule. It's taken once a day, so that's definitely the most convenient formulation that we'll try our best to get approved. We have great success with that. But then there's also like a Mantidine immediate release tablets that may be taken like twice a day. So these are options to kind of add on if we like have your carbidopa levodopa regimen like really great, but you start having like side effects because of it. If we can't lower your dosing regimen, then we would think about adding on Gocovri or a Mantidine, okay? All right, and then I think this is the last class of add-on medications that I have, and these are just called anticholinergic. So there's very old medications, we use them for a lot of things, but they do have activity on dopamine, so they have a utility or a usefulness in Parkinson's disease also. These medications are benztropine and trihexyphenidyl. It's a mouthful, but these are medications that typically we take them 2 to 4 times a day, so there is an inconvenience factor there. But you know, could be useful as add-on if you're on carbidopa levodopa still experiencing symptoms. We hesitate to use these though, because anticholinergic drugs, a lot of medications have these side effects, have anticholinergic properties, but we have like a mnemonic for this. And I don't want to scare you with it. I'm going to go through it. I want to be clear. None of these side effects, like these side effects don't necessarily happen in everyone who takes these medications. And I've never met a patient who experiences all of these side effects, but these are the possible side effects of anticholinergic drugs. The mnemonic is mad as a hatter. So it can cause some confusion, cognitive impairment. We're monitoring for that. We're obviously not going to use it if it happens. Red as a beet and hot as a hair. So it can cause like flushing and feeling like you're overheated. Dry as a bone, so dry mouth is something that we will always ask you about if you're on a medication that may cause that. So if you're ever wondering why we're asking, it's because the medication might have a side effect like this. Blind as a bat, so it can cause dry eyes and blurred vision. So we're always going to be asking about that as well. And full as a flask. So it can cause urinary retention or the inability to like release your urine when you need to go pee. So always be monitoring for that as well. We don't want that to happen. So these 2 medications definitely have a place in therapy. We are careful about using them though, but they are options. Okay, we can go on to the next slide. And let's talk about some fun medications to treat off periods. So let's say you're taking carbidopa levodopa 5 times a day, 6 times a day. But you know, after that 3 o'clock dose, for some reason, I always freeze up before it's time for my 6 o'clock dose or wherever your next dose may be. Like you're always freezing prematurely, but you're like, well, I don't want to like add another dosing regimen to my day. Like I don't want to take, carbidopa, levodopa 6 times a day. I'm already taking it 5 times a day. So we have some like as needed options that you can take at home. So you're freezing up, you're obviously like highly symptomatic. We want to treat you fast. So we're going to focus on medications that you can use on an as needed basis at home whenever you feel yourself freezing that work within 15, 30 minutes for sure. So there's some pretty unique dosing regimens here. So we're basically, how can we give you dopamine super, super fast? Let's go to the next slide. And that is, well, I kind of already explained this. So these off periods are, the kind of gray box is where your carbidopa, levodopa is working well. You see these doses like falling off and you have these pink little freezing periods. So we need to give you something that works fast to treat those, to get you back to your baseline. So let's go to the next slide. And these are the rapid acting dosage forms that we have. So we have sublingual films, we have an inhaler, and we have an injection. Okay, yeah, good. I did put the injection in there. I have actually like samples, non-active drug of the inhaler and of the sublingual films that if you would like to come up and like check them out after. They're unique dosage forms, so they're not for everyone. But hopefully we can find one that does work for you. So again, the whole point, giving you levodopa fast. So we have apomorphine, which is like a dopamine agonist. It's a sublingual film. So that's the Kenmobi is the brand name. And I want to be clear, I'm in no way like pushing these medications on you. These are just the dosage forms we have available. And I do have like manufacturer samples. So these are little sublingual films. You know those breath strips you can put on your tongue? They're like that, okay? But you put them under your tongue. So, you have to wet your whistle, like put a little water in your mouth, get it moist, swallow that water, then place the sublingual film underneath your tongue. And it should start working definitely within 15 minutes. You'll start seeing those effects and it'll start helping you unfreeze. Not for everyone. I've had a couple patients say like, yeah, I had a difficult time opening the film that the medication was in. They had a hard time actually ripping this open. So this is kind of what it comes in. There's a film inside of here. So you kind of have to rip it. They had a hard time with that when they were having symptoms. So that's definitely a consideration. But should work pretty quickly, comes in a lot of doses. So when we start this medication, typically I help our neurologist start it, and I touch base with you guys over the phone every 2 days and say, okay, how'd the 2 milligrams work? How'd the 4 milligrams work? How'd the 6 milligrams work? And we kind of let you try them all from the low dose to the high dose until we find the one that unfreezes you. And then I send in that script and we get that started, okay? So we use little sample packs. So it's really interesting, a really unique dosage form that can work really quickly. Obviously, if it dissolves under your tongue, it's absorbed in your mouth way quicker than if you took a tablet by mouth and it had to work all the way to your stomach and then get broken down and then absorbed. So that's why that works quicker. We also have apomorphine injection. So the same medication that's in this sublingual film comes in a shot form. So it's subcutaneous shot. So you think if anyone has diabetes or has friends or family with diabetes, they inject insulin just into that fat layer under the skin. Same type of thing. Not very painful, but some people don't want to have to give them shots. And it comes in this pre-filled pen, which is with the needles in the case. So it is convenient in that way, but that's also an option. Obviously absorbed much quicker from your fat layer than it is from your stomach. And then our last one is the Inbrija is the brand name. It's a levodopa inhaler. So it's an inhaler that you use by mouth. It's really unique, but it is kind of weird because it has these capsules. I won't pull them out now. These are obviously placebo, but you basically drop a capsule into this inhaler, puncture it, and then inhale it. And that is pure levodopa here. Okay, so inhaling it obviously allows the levodopa to be absorbed super quick. So that's an option as well. Again, when you're symptomatic and you're kind of having a difficult time with coordination, this might be difficult. You have to take the lid off. You have to twist this off, unwrap a capsule, drop the capsule in, puncture the capsule, and then inhale. The kicker is it's 2 capsules per dose. So you got to do that twice. That's a full dose of this inhaled levodopa. So definitely an option, especially if you have a caregiver with you all the time to help. But these are that's kind of the third unique dosage form that we have. Yes, question over here.
My experience with testing that product for it is it's hard to hold that dust in your lungs.
Yeah.
So that's also another encumbrance, I think, to using it.
Like, you mean like without coughing? Yeah.
Not cough.
Yeah, you're supposed to hold your breath for at least 5 to 10 seconds after inhaling it. So we're looking at taking a deep breath, holding that in for a while and not like blowing it back out. It's a dry powder. I don't know if anyone uses other types of inhalers, but your breath and you sucking in is what's activating. That's what's pulling the medication out of that capsule. Nothing else is like pushing it out. So you have to take a deep breath. You got to hold it in. You got to not cough it out. So that's definitely a barrier and something to think about. If you're ever like in our office, we could have you like trial a dose with the placebo and see if that's something that you can do. But if you have a different neurologist, you can obviously ask to do the same thing there if you're thinking about using this medication. Interesting dosage form for sure. Okay, any other questions about those? All righty, so those are kind of our off period treatment options. In addition to, we could just go old fashioned and just give you an extra carbidopa levodopa tablet and ask you to chew it. So that's an old school option that we can absolutely also do. And we might try that first just because of the convenience factor there. Okay. All right. So let's talk about briefly, I've told you about all these medications, but I haven't really talked about side effects of them. And the reason I did that is I saved it for the end because all of them work on dopamine. So all of them have very similar side effect profiles. When you're taking multiple medications, let's say you're taking carbidopa levodopa 4 times a day, and you're also taking like a dopamine agonist, right? They're both working on dopamine. We're increasing your dopamine stores, or at least mimicking that action. But you're on more than one medication that's doing that. So those side effects are possible and they are additive, right? So, someone who's on 2 or 3 dopamine agents might be more at risk for side effects than someone who's just on carbidopa levodopa. But we're going to work to manage those. So the most common side effects are, I kind of hit on it when we talked about carbidopa levodopa initially, are nausea and like GI distress, or like stomach upset, having either constipation or diarrhea. Nausea is really the big one. And that's why, it helps if you take it with food, but we already talked about the food concern. But it's more important that you get some levodopa. So if that happens and you cannot tolerate it without food, we will absolutely encourage you to take it with your meals. So that's kind of the one way that we manage that. Another way to manage the nausea and GI upset is by starting doses really low and moving up slowly. So sometimes I'll have a patient, okay, you're on carbidopa levodopa 25-100 milligrams 3 times a day. For this first week, let's just take 1 a day. The next week, let's do 2 a day. The next week, let's do 3 a day. And we gradually increase your dose until we find that dose that works for you. And that really does help with GI tolerability. Typically, this GI tolerability, this nausea gets better after about 2 weeks of starting the medication. But those 2 weeks, we're listening to you. They could be rough. And we'll do whatever we can to help you get through those, okay? Orthostatic hypotension, really fancy words for when you are sitting down and you stand up and you get dizzy. That's orthostatic hypotension. That means that your blood pressure is dropping when you go from sitting to standing. So this is a potential side effect of agents that act on dopamine, like all of the drugs we've talked about up until this point. But it is also a potential side effect of Parkinson's disease as a disease state. So Parkinson's disease itself can cause your body to not be as good as regulating your blood pressure when you change positions, when you go from laying down to sitting up, from sitting up to standing up. Obviously, this is a problem. We don't want you to get dizzy when you stand up and then start walking and have a fall. We definitely want to prevent that. So I'll kind of talk about how we manage that in just a little bit. We have some non-pharmacologic options. We have some drugs we can use as well. And then we have hallucinations or delusions. That might be scary, but I want to say that it's pretty rare. Hallucinating, of course, is like seeing things or hearing things that other people don't seem to see or hear. Delusions is having, you can think like paranoid delusions are pretty common, like feeling like someone in your family is out to get you or your caregiver is actually out to get you. Things that aren't true, but you imagine them in your head as being very, very true, and they're very real to you. So high doses of dopamine, we start watching out for this and we start saying, okay, how are we gonna get rid of this? Can we lower that dopamine load? Can we take some dopamine away? We gotta weigh the risk benefits. Like what's important to you? Like, do you, I've had some patients say, yeah, I see some farm animals in my living room sometimes, but I tried taking my levodopa down and I don't like to freeze up. So maybe they kind of weigh that and we can maybe add on like a medication to specifically target those hallucinations instead of lowering their dopamine load. So it's very customized. We're going to be asking about it. It's still a rare thing, but treating Parkinson's disease patients, we do see it. So we have some tools in our pocket that we'll get to in just a minute. All right, let's move on to the next slide. And we'll talk about some non-motor symptoms of Parkinson's disease. In this section, I'm going to talk about, non-motor symptoms. A lot of those are actually some of those side effects we just talked about. So we'll go a little bit deeper into what our approaches to treatment are and like what conversations we would have if we needed to address these. Go on to the next slide, please. Again, orthostatic hypotension, a potential side effect of dopamine, also happens with the disease of Parkinson's disease itself. So we'll talk about managing that. Cognitive impairment. So Parkinson's disease and mild cognitive impairment or even dementias are related. So how do we approach that if we see that happening or if you're experiencing those symptoms? Depression, anxiety, and then we'll hit on psychosis that we just talked about. Depression and anxiety are very much related to the disease. So how do we treat people with Parkinson's disease compared to the general population? And then we have urinary issues. So we can have urinary frequency, urinary urgency, meaning that when you got to go now. We don't want you to experience accidents. So kind of what are our approaches to that? Okay, move to the next slide, please. Okay, orthostasis. So again, that means you're getting dizzy when you stand up. You're really, really tired. The body can't regulate your blood pressure the same way it used to. We're going to address non-drug therapies first. So we are going to ask that you increase your water intake. How much fluid you have in your body really supports your blood pressure. So we're going to ask that you increase your fluid intake. Start using maybe like electrolyte packets, like liquid IVs, like Gatorade packets. When you put some electrolytes in a bottle of water, your body thinks you're taking in a lot more water than you are. So we're going to incorporate that first. There's also a lot of evidence with patients who, they stand up, they feel dizzy, they check their blood pressure is low. Chugging to like a 17-ounce bottle of water has been proven to like help those symptoms resolve. So we're going to ask you to implement those practices first. We can also look at other things like compression stockings. So for your legs, that helps the fluid support in your body. And also there's some like compression like wraps that can go around your abdomen that have been proven to support your blood pressure as well. So we might try those also. And then physical counter maneuvers. So there are certain like positions that you can sit or lie in that will help your blood pressure regulate. So there's like positions where you like lay on your back but like cross your legs over each other. And that really helps like support your blood pressure when you change positions. So there's a lot of like non-drug things we can try first, okay? But then we have medications, and that's typically when our patients get sent to me. When, we have to start, what are some medications that we can start and like follow your symptoms, and we have to titrate those, which means like increase the dose until we find the right dose for you. So oftentimes Dr. Kabulnarak or Dr. Bailey will say, okay, Corey, work with this patient's cardiologist, like make sure they're aware that we are starting a medication that's going to increase their blood pressure. We're doing that on purpose, and also just follow up with them and ask them to check their blood pressure at home, report those readings to you. You guys decide like how to change the dose based on their symptoms. So Mantidine is one of the first ones we typically use. It's a medication that basically helps like narrow or like clamp your blood vessels to increase your blood pressure. And it's taken 3 times a day. So inconvenient, but it's a really effective agent. So we might try that one first, start at a low dose, have you check your blood pressure about an hour after taking it. We'll talk every few days and then, increase the dose thereafter. Once we maximize midodrine, I typically go to fludrocortisone. So fludrocortisone is actually a corticosteroid. So you think you've taken steroids in the past. This one works a little different. This one actually works by eliminating how much salt and water you're getting rid of in your urine. So it helps you hold on to salt and water. That's a good thing when you have low blood pressure. Okay, so we want you to have more fluid, similar to how we're going to ask you to take in more fluid, drink more water. This medication is going to help add on to that. So we might add on fludrocortisone next, and then finally droxidopa, which it works pretty similarly to midodrine by clamping those vessels and increasing your blood pressure in that way. It is also taken 3 times a day, and we can titrate that one really fast, like every 2 or 3 days, we can increase the dose if you're still having symptoms. Obviously, we are very careful about making sure your blood pressure doesn't go too high. We don't want to throw you into that opposite problem, but we want to treat your symptoms and alleviate that dizziness or tiredness that you're experiencing when you stand up and your blood pressure drops. And we have a question? Yes, good question. So the question was, what about supplementary salt tablets? Those absolutely have a utility. So basically, the only problem with supplementary salt tablets is you have to take a lot of them. So I don't know if anyone's ever gotten a bag of normal saline and IV, if anyone's ever received medications through an IV, 9 salt tablets, so sodium chloride tablets that you take by mouth, 9 of them are equivalent to 1 bag of normal saline. So that's a lot. These tablets are pretty large also, so that can be inconvenient. They're big white tablets, typically about a half inch or so. So that could be a barrier to that. Absolutely an option. Yes? Fludrocortisone? Yeah. If you take fludrocortisone and salt tablets, yeah, theoretically, that's gonna kind of boost how well fludrocortisone is working, right? Because we're already adding more salt. We'll also encourage increasing your dietary salt intake. So absolutely, we can absolutely get creative and kind of add multiple medications on top of each other. So salt tablets, absolutely an option. We just gotta zoom out and think about, okay, how many tablets are you already taking 3 or 4 times a day? And are you okay with adding more to that? Because we're gonna be, fludrocortisone is only once a day. So that's the convenience of that. You can't take it twice a day, but midodrine and droxidopa are 3 times a day. So we got to consider all of those things. Okay, any other questions about orthostasis? Yes. It's a catch-22 if you're a heart patient. Exactly. So, we would probably stay away from fludrocortisone in that situation because we don't really want more fluid to be adding stress into your heart. Midodrine is a medication that can be used in heart failure patients when your heart stops putting out as much blood as it used to. So that would probably be my number one to go to there. I would try that first, and I would just make sure to work really closely with the cardiologist and make sure everyone's on the same page. But that would be the first thing that I would go to. But yeah, you have to be careful about fluid retention in patients with heart disease because that can put more stress on the heart. So it's a catch-22. That's a really good question. All right, any other questions? Okay, very good. Let's go on to the next non-motor symptom of Parkinson's disease, which is cognitive impairment. So you can think of cognitive impairment as anything from mild cognitive impairment or memory disorders to dementias. So our approach in patients who have Parkinson's disease and are experiencing mild cognitive impairment is the same as the general population. We have to take some considerations into account, but some of our first line therapies is going to be acetylcholinesterase inhibitors. So rivastigmine or donepezil, which is brand name is Aricept. You might have heard of that one before. But these come in both oral tablets, and rivastigmine comes in patches, which may be a really convenient thing for some patients. And how these work is basically, instead of dopamine, acetylcholine is the problem in memory disorders. So these work by increasing the amount of acetylcholine in our brain. So those will be our first line. And then second line, we would use or add on NMDA receptors. So basically, these medications are just pretty like down regulatory for the central nervous system, and that helps with our memory impairment. And this is Mantidine, and it's an oral tablet. So we would probably start with the acetylcholinesterase inhibitors there. We would monitor your vital signs. So it can cause high blood pressure sometimes and low heart rate. So we definitely don't want that to happen. Low heart rate can make you feel tired. So we don't want that. We'll monitor for those. Donepezil and rivastigmine and galantamine can also cause like stomach upset. So sometimes we ask you to take that at night to help kind of get rid of that side effect. If you're sleeping, you won't notice it. Okay, so very similar approaches to cognitive impairment as the general population. Okay, let's move on to the next one. And we have depression and anxiety. So similar to cognitive impairment, we take the same approach to treating depression and anxiety. We are going to look at cognitive behavioral therapy, or just like talk therapy first, but I'm going to, for the sake of time, focus on the medications today. SSRIs, SNRIs, and TCAs, tricyclic antidepressants. I just threw a lot of letters at you, but those are kind of the same anxiety and depression meds we use in the general population, so patients who do not have Parkinson's disease as well. SSRIs are things like sertraline or Zoloft, paroxetine or Paxlovid medications. So those are really great first line agents. SNRIs are very similar to SSRIs, but you might have heard of meds like duloxetine or Cymbalta before, venlafaxine, and then tricyclic antidepressants are a third class I'll talk about in a second. With SSRIs and SNRIs, they're typically very well tolerated. Sometimes they can cause like stomach upset when you first start them. We take them with food to try to get around that. Consideration is sometimes, not always, these can exacerbate a tremor. So that means they can make a tremor worse, especially if a tremor already exists. So we monitor that pretty closely when we start these. All because it happens with one SSRI does not mean it will happen with another one. So we might try more than one if that does happen. When you stop the drug, tremor should go back to what it was like at baseline, but that's a special consideration for our patients who have Parkinson's disease. Tricyclic antidepressants may be a decent option sometimes. These are amitriptyline and nortriptyline, so really effective antidepressant agents, but they have those anticholinergic side effects. Anyone remember that mnemonic? Mad as a hatter, red as a beet, hot as a hare, full as a flask. So dry mouth, cognitive impairment, they make you really sleepy. Those can happen with these agents. So we're a little more hesitant to use those as like a first line option, unless let's say we're having difficulty with depression and also your sleep is really impaired because of it. So we might try these in that situation, because we can kind of exploit those side effects to help you out. But that's kind of the rundown on how we approach anxiety, depression, in patients who have Parkinson's disease. Okay, next slide, please. And we'll talk about, I believe, hallucinations and delusions. So in those rare situations where we do have patients who start experiencing hallucinations or delusions, we have to be very, very, very careful about what agents we use, because a lot of medications that we use as like antipsychotic medications, so like anti-hallucination medications, work directly by limiting dopamine. We already have a problem with low dopamine. We don't want a medication to come in and kind of cut off all the benefit that we've been trying to get with our carbidopa, levodopa, all of our dopamine agents. So we have to be very careful about what agents we pick. And we kind of have three that we typically go to. So quetiapine or Seroquel is a medication that doesn't work too much on dopamine, but can help treat hallucinations and delusions. So that's a really good first option. It does make patients sleepy sometimes, especially at first. So it might be something that if this starts happening, we dose it at night and increase the dose until we start seeing the effect as long as you're tolerating it okay. Then we have clozapine. So clozapine is kind of very similar to quetiapine. It's taken once daily at night. It's very, very, very effective, typically in my experience. It comes with issues though. It can cause some low like white blood cell counts, something called neutropenia, where your blood isn't making as many neutrophils, which are a very important type of white blood cells, as it used to. It's a rare side effect, but there's very strict monitoring that has to go on when you first start this medication because of it. So my patients who are on clozapine have to get labs every week for 6 months. So, you know, it's only right for certain patients who have like close access to a lab they can pop over to once a week close to home. But it is highly effective. So there's definitely a trade-off. After 6 months, we go to monthly labs. And then we have Nuplazid, which is pimavanserin. Nuplazid is the brand name. Nuplazid came out a couple of years ago, I think in 2018. And it was kind of like this novel antipsychotic medication that is only indicated for treating hallucinations for patients who have Parkinson's disease. And the reason is this is the very first antipsychotic we have that does not affect dopamine at all. It works strictly on serotonin, which has a big role in hallucinations. So it's very like safe for patients with Parkinson's disease. I've seen it work wonders in patients. I've seen it not work in one patient. So it's something we're gonna have to monitor, but great option, once a day dosing, super convenient. It's brand name, it is expensive, but I haven't had problems getting it approved yet for any patient. The manufacturer who makes it actually has really great like patient assistance copay programs if it's unaffordable. So I haven't had any issues with that yet. So that is a really great option as well. Okay, so we can go on to the next slide. Thank you. So I think this is the last non-motor symptom slide that we have. So treatment of urinary symptoms. So we kind of talked about urinary frequency and urgency as happening in some patients who have Parkinson's disease, meaning that when you gotta go, you gotta go. So of course, we're gonna try to address some like non-drug treatments first. We might encourage you to try scheduled voiding, which means you're going to the bathroom every hour and a half all day, no matter if you have to go or not, because that really helps like reduce that urgency. So that's one option for sure. Bladder retraining. So just really fighting it off when you feel the urge to go, to kind of retrain your bladder to say, okay, wait, no, I can hold more urine than this. Bladder retraining is absolutely an option. Pelvic floor physical therapy, especially for women, can absolutely be an option to kind of strengthen some of those pelvic floor muscles that, you know, when we relax them, that's what releases our urine. So that's absolutely an option as well. We have amazing urologists in Wilmington that can help us out with all of these things. And then we have medications to use. So oxybutynin, which comes in many brand name medications. So Myrbetriq, I put that on the wrong one, sorry. It's actually just ditropan. It comes in a patch form, it comes in like a gel that you rub on your body, it comes in tablets. So those are options. It basically just helps relax the muscles that is your bladder, so that it doesn't like spasm and say, okay, you gotta go now. So that's how that works. Also has those anticholinergic side effects. It works on the same receptors. So we worry about urinary retention. That's literally the point of this medication. We're giving it to you to cause urinary retention. We don't want you to be able to release your bladder when your bladder is saying you gotta go. But those other side effects, that dry mouth, that flushing, that confusion, we don't want any of that to happen. So we're monitoring for that. Sometimes I prefer, if I need to start oxybutynin in a patient who I think might be sensitive to those side effects, which can happen more in older adults, the extended release formulation tends to have fewer of those side effects. So that's kind of my go-to. And then Myrbetriq is a better and safer option. It works to also relax that bladder muscle, works by a completely different mechanism. So it does not have those anticholinergic side effects. So we don't worry about that dry mouth, those blurry vision, the confusion. We just worry about low blood pressure. It can sometimes cause your blood pressure to be lower, which may not be a bad thing, but if you have orthostasis, it may be. So definitely taking all of those into considerations when trying these. And we have a question.
Yeah, this is from online. What is the medication that helps apathy?
So the question online was, what are some medications that help with apathy and affective disorder? So that means kind of having like, we call it like a flat affect, like not really caring about things that you used to care about. You know, you're less like emotional, you're not really exhibiting your feelings when you're talking to your loved ones. So that's what we call like apathy. So not really being able to feel those feelings. And we would treat that primarily through using antidepressants first. So we look at those SSRIs, those SNRIs that we talked about a couple of slides ago. And in some patients, if we've tried like 2 of those, we might look more toward those antipsychotic medications, the quetiapine, the clozapine. So those have all been shown to kind of impact apathy or having like a flat affect. So it's definitely like a symptom of depression. So what's the root cause? Depression. We're going to target that. And we have another question.
What about Gemtesa? Gemtesa? It has less side effects than my verdict.
Gemtesa. Yeah, so Gemtesa is like a new Myrbetriq. Okay, the question was, what about Gemtesa, which is a urinary agent? It is very similar to Myrbetriq, which is this one right here. And it's basically like in the same drug class. It's just a newer one. Honestly, I just forgot to put that on here, and I thank you for pointing that out. But it's like a newer Myrbetriq that has less of the effect on blood pressure. So it's kind of like the new safe agent to use. With these both, cost could be a barrier. We might have to try an oxybutynin first to get that approved, but we'll go through that process with you or loop in your urologist if necessary.
And related to that, she asks, do you help with insurance coverage?
I do, yeah, within our practice, absolutely. So you can call the clinic anytime. Dr. Popolnarak's typically pretty okay with me seeing any of her patients that might need medication access. I have some tools up my sleeve. I definitely work with the drug manufacturers. A lot of times they have really great copay support programs, but it's just kind of a time constraint to communicate with them and get that all set up. So that's literally what I do. And then also like I can help you utilize other pharmacies like our hospital pharmacy that gets drugs at a discounted rate and then can provide them to our patients for discounts. So with those expensive drugs, like we have many options and I absolutely kind of take the lead on those. So please share with your providers if you're having cost issues, like do not be embarrassed about it. I couldn't afford a lot of these. So definitely share that with us, see what resources you have. I'm a resource at our clinic at Novant Neurology. Okay. Any other questions about these? I think this might be the last slide. What's next? Yeah, it is the last slide. Okay. So I want to open the floor. Any other questions? Thank you to everyone who asked questions throughout the presentation. I think that was really great for the conversation. I'm sure other people had those questions as well. But are there any other questions now? Yes.
I have a question.
Topiramate, yes. Topamax, yes.
What is that used for?
That is such a loaded question. The question was, what is topiramate or Topamax used for? Topiramate was originally an anti-seizure medication, but now we use it for so many things. It can be used in mood disorders, so as like a mood stabilizer, really useful in patients with depression or even bipolar depression. But where we use it for in neurology most, outside of seizures, is tremor. So it has a lot of evidence, really successful option for managing tremor in patients. So for patients who may have a tremor, but we don't really think they have Parkinson's disease, like there are tons of other types of tremors, then we may look toward using like specifically just tremor medications. So things like primidone, you might have heard of primidone before, that's a tremor medication. Also topiramate, we typically try topiramate or Topamax after that. And then Propranolol, which is actually a beta blocker. So a lot of people use it for like blood pressure. That one has a lot of evidence for tremor as well. So typically we try to reserve those for patients who may have tremor, but we don't think they have Parkinson's, because if we think they have Parkinson's, we want to focus on dopamine agents instead. Okay, so definitely an option for tremors though. Yeah, no problem. Any other questions? Yes. Sorry.
But it's not alternative to say deep brain stimulation.
Topiramate so the question was, is topiramate an alternative to deep brain stimulation? It technically is. We would typically try to use topiramate, like primidone, topiramate, propranolol, before we consider deep brain stimulation, just because of the invasiveness of the DBS. So it's technically an alternative, absolutely. And some patients who have a DBS or deep brain stimulator also will be on one of these like oral medications to help co-manage it. Yes. Any other questions there?
So my experience, I was misdiagnosed with essential tremor.
Yes.
For several years.
Yes.
Always took care of it.
Mm-hmm.
So it did.
Mm-hmm.
That's when I got the problem.
Okay.
So personally, going to certain ones like beta blockers
Yes.
was out of the domain of
Right. Like, so the testimony is that thought to be essential tremor, propranolol managed it very well for years, and then it didn't work anymore. So then he was properly diagnosed with Parkinson's disease. And so that can absolutely happen. Now we don't think that your tremor is essential. So now we think that dopamine, a lack of dopamine might be causing it. So perhaps more dopaminergic agents might be options. We can absolutely still try adding on those topiramates, those primidones also, but maybe trying dopaminergic agents might be a good option, or going toward DBS or deep brain stimulation. So it's definitely like a cocktail, and we got to play around with it. But yeah, it's going to be customized to each person. Thank you for sharing that. Anyone else have any questions? We got a question over here. Very good question. Very good question. Is there any concern or relationship with acting out dreams in Parkinson's disease? And that is actually one of the first symptoms of Parkinson's disease in a lot of patients. So when you were diagnosed, you might have been asked, are you smelling things differently? Are you unable to smell now? And how is your sleep? Has your partner noticed any sleep disruptions? Because sometimes those are like prodromal, or like before you get motor symptoms, you start experiencing those. And the reason is something about Parkinson's disease disrupts your REM sleep disorder, rapid eye movement sleep. You know, that's the deep sleep we go into whenever we dream. So whenever you're experiencing REM, or rapid eye movement sleep, you're, instead of being like paralyzed like we normally are in REM sleep disorder, you're acting them out. So that is definitely an early sign of Parkinson's disease. Absolutely. Yes, no problem. And we have another question.
Are there any alternatives to omeprazole for reflux with PD patients? Does it deplete your B12 and affect cognition?
Oh, that's a good question. Okay, so there was a lot of literature in the early 2000s. The question is, does omeprazole deplete your dopamine, your DP12? And are there any alternatives to that? So there was, and if you Google it, you're gonna see, is like omeprazole worsening Parkinson's disease, or is it causing dementias? There was a lot of literature for looking at patients who studied drugs like omeprazole, which is used for like acid reflux and heartburn. It's a once daily medication leading to those diseases. The evidence isn't really convincing. We don't want you to use it any longer than you need to, because it can cause other problems, like your bones can get weaker. There's a potential risk of infection if you use it a long time, but I'm not very convinced, and I'm not concerned about my patients' safeties who are using omeprazole or esomeprazole. So you can think of drugs like Nexium, Protonics, like you can see them at any pharmacy over the counter. You can also use medications that are histamine blockers. So histamine causes acid production in your stomach. So think of medications like Pepcid, like famotidine, or really we always use famotidine now. There was some issues with ranitidine a few years back that caused them to be recalled. So like Pepcid are like another option, but those are taken twice a day instead of once a day. So something to consider. But I understand like if you Google it, you might get scared. The literature is not convincing, and I don't have any problems with our patients taking proton pump inhibitors like omeprazole. Okay, any other questions? I've really cut into the time. Yes, question here. I got a doctorate in it. It's okay. Thank you. All right, any other questions? I'm so sorry that we cut into our second hour. I hope that you all benefited from this. Please call our clinic. If you want me to email you a copy of this slideshow or talk to you about your medications in any way, help with anything else, call Dr. Pobulnarak's office. I work right there in the building with her, Dr. Bailey's office, Michelle's office, and I'm happy to help anytime. Okay? Thank you. All right. Oh, that's great to know. I actually have another handout I think I would like to share, just like a one-pager on drugs that you should like make sure all of your other doctors aren't using in Parkinson's disease. We didn't really get a chance, we didn't have time to go into it today, but I would love if we could share that flyer there as well. I kind of highlighted the big ones. Okay. Yes. Oh, sorry. Could you repeat the Facebook group's name?
Sure, it's called Parkinson's, with apostrophe S, Parkinson's. And it'll pop up, and behind it it'll say ILM for Wilmington.
Okay.
Thank you.
So that was.
It's a private page, so it's just us that's on it.
Yeah.
And I'm the administrator, so when I see that a new person is asking to be let in,
Yeah. Thank you. So yes, everyone go join the Parkinson, so with an apostrophe S, support Facebook group. It'll come up and it'll say ILM for Wilmington after. Please go join that. These slides will be posted. I assume we post slides from every session there, and just ask to be a member and you'll get approved to get in, okay? And do we have a question in the back? No?